big change. But I remember, and it's something, this is something very so powerful. But at the same time, so simple. When I got my breast done, and I looked in the mirror, and I started crying, tears, and I was like I'm so happy. This is happening. I'm changing. I'm being myself. It's time. So for us, it's very important to have places like the LGBTQ Center at the UM Hospital. It's so important, and we're so thankful for it. And it's actually a big step. It sounds like it shouldn't be a big step, but it actually is. For the hospital, for a general hospital like this, it's so big. It's very easy to be scared to make a change like this, but it's so great.
Personally, my fulfillment is I've taken care of a lot of patients who've had cancer, they're extremely appreciative once the cancer has been removed and reconstructed. And this is the same feeling I get with the transgender patient population. You really feel like you've changed their life and actually saved their life. And so it's really akin to that, taking care of a cancer patient. That's how it's felt for me. And that's why it's really made me really attracted to this field.
I love it. I love this center.
Yeah. What time?
Okay, that was very short. Was that the whole thing?
I don't think so.
Anyway, I'm really happy to be here and be a part of TransArt this year. It's, as Dee was saying, you can be who you want to be. You can change your body. This is the gentleman to go to if you want to change your body. I know because I work with him. One thing that sets, you saw a little video about our center, LGBT Center, which is one of the first of its kind in the country. And they have somebody like myself, who's the concierge director there, providing these services for other trans people to come. You know, a lot of times trans people go and have surgery, they go to ambulatory centers or places that are not hospitals, and they don't have anybody that go with them. And I provide that unique little part of their transition where I can hold their hand, I can walk them through this journey. And that's a very important role. And I'm honored that a place like you, the University of Miami, would hire somebody like me to help their patients. It's a great asset for us to have, and it sets us apart from all other centers. I actually met Dr. Salgado at a meeting like this, I believe, at the Hub a couple of years ago. I think it might have been something to do with TransArt, I'm not sure. And I have worked with him now for over a year. I've seen he's very compassionate towards the trans community. He loves all of us. I mean, I see it on a daily basis. Sometimes he doesn't participate. I mean, it's crazy. He does wonderful things, and it's a great honor to introduce him to you today. He has a wonderful presentation. And so sit back, enjoy your food. You might want to eat after the presentation because there are a couple of fun little pictures that you want to see. But it's a great honor to be here. I'm so happy to be here, part of TransArt again. Thank you, Araya Lester. Here is those that was not here. But it's a great honor. Here we go, Dr. Christopher Salgado.
Thank you very much. I do a lot of talks and a lot of times in a professional, to other physicians, and it's certainly, I always look at these talks as more like the grassroots type of talks because you get to meet a lot of patients, transgender persons, that potential patients, but that more so you get to hear them and hear their concerns essentially, and it's nothing like really talking to them. In this type of setting versus in a hospital is a little bit different because they're your patient here. Here you're not. Here you're just kind of chit-chatting and kind of figuring out what their real needs are. And so it's certainly a lot more satisfying for me to be speaking at these type of settings than the other setting that I normally speak at. I'm kind of going back and forth here. So our disclosures, essentially the book in gender affirmation surgery, and I've noticed this is really the most popular book in plastic surgery right now. As you know, a lot of procedures are covered by insurance. So there's a lot of physicians, healthcare providers that are getting into the field, which is good for the trans community. And so because insurance is covering the procedure, so I think that's definitely a positive, very positive thing. It's very important to have meetings like this, and then have a lot of people that are more outspoken. I don't know if Dee left, but she seems like a very knowledgeable person, and it's someone that you need to have on the Hill to really voice concerns of the trans community, because I think that's one thing that's always lacking. And a lot of people really just don't get it, and they confuse oftentimes one's sexual preference with one's gender. And I think it's very important for them to really realize there's a big, huge difference. Even though LGBTQ is kind of lumped together, one's a sexual preference and one's a gender identity. And oftentimes they'll say, oh, they think that you choose to be a trans woman. Yes, you do in part, but part of it is also the fact that you're really wrongly gendered, at birth. And so I think a lot of people on the outside don't really get this, and I think it's important to really reinforce that to them. Just like Ms. Weingart in her talk, I will use the words penis, dick, vagina interchangeably, and because I feel like that's the way to keep it real, and that's really a lot of ways that I speak. So we follow the WPATH, World Professional Association for Transgender Health guidelines. We follow them strictly, somewhat. They're clinical guidelines, but it's definitely important to have this, particularly for new healthcare providers, for them to become accustomed to the care of the transgender persons and their care. We do surgery primarily on trans men, trans women, and then some gender non-conforming patients. As you know, they're more on a gender spectrum. We try to do more reversible procedures on patients that are gender non-conforming. So that's usually top surgery, facial procedures. Gender non-conforming is not the same as gender dysphoria. However, they do have elements of gender dysphoria, and that's oftentimes, if you want to get insurance to cover these cases, for gender non-conforming, it's not really covered yet. However, if you say that since they have elements of gender dysphoria, then you can also give a diagnosis of gender dysphoria to get these cases covered by insurance. One thing that's sort of the WPATH is dealing with in terms of the International Classification of Disease 10, ICD-10, is they want to classify, right now it's classified as a mental health issue, but they're trying to classify this as a sexual health issue. And I'm not sure, I'd like the opinions of the crowd here and what their thoughts are on that. I feel that sometimes that if you call it a sexual health problem, then you're going to have people that on the Hill that might be less apt to cover these procedures. So I think we have to be very careful on how this is classified. And so I've had close discussions with the WPATH about this. We want to make sure that these cases are still covered by insurance, and give it whatever diagnosis you want. Ultimately, it's all about the patient and their transition and getting the cases covered by insurance. So we have to be very careful in how this is classified in terms of the International Classification of Disease, ICD-10. What's the incidence? It varies. Usually as more services are provided, more and more people sort of come out for care. So this is an old study by the Williams Institute, 2011. You're saying that there are about 700,000 gender persons, transgender persons. In the VA alone, this stat's 140,000 in 2016. So there's a lot of vets that we operate on and care for that are Army, Air Force, Marines, Navy. The Census Bureau estimates 1.4 million now. So this is at a study in the New England Journal of Medicine. There's about 1.4 million that's classified as gender transgender. So that's 0.6% of the population. As far as the hormones that patients go on, and you're probably very familiar with this, breast growth when you're on estrogen maximizes at about 2 years. So normally we don't do the breast augmentation until about 2 years into it. Estrogen does not have that much influence on voice, so often our patients will undergo speech therapy for voice therapy, or so you can get feminizing laryngoplasty. We have a guy now in the ear, nose, and throat department at our university that's doing a lot of feminizing laryngoplasty on our patients to help patients with voice. Testosterone, on the other hand, does influence voice, so for trans men, it's very rare to undergo an operation for that. And then other aspects that you get, obviously the facial hair growth, as well as increasing your muscle mass. For the trans women that are on oral estrogen, we always caution them to be careful with this. We always actually sort of get them to get on the patch or the iron injections. And a big reason is because of the study here. It's out of the Netherlands. It showed that transgender women are 51% increased risk of mortality, that's death, compared to cisgender women. And that's because of cardiovascular complications. So there are measures that we take when we operate on trans women, like getting ultrasounds of their legs, make sure there's no clots in their legs, which can be very prone to clots. We do that before the operation and then after, upon discharge. But yeah, this is a real study, and you have to be careful if you're on oral estrogens. I know it usually feels good for the patient to be on oral estrogens, but it's this is a real study. It's a real issue if you're on oral estrogens. So I would strongly recommend a patch or iron injections. Our requirements for surgery is typically 1 letter for top surgery, 2 letters for bottom surgery, and there's no letters required for facial feminization. A lot of gay men that come in for facial feminization procedures, they're not transgenders, just homosexual men. So this is an area that the WPATH is not enforcing at all, and that's letters for facial feminization. That's not needed at all. There are a lot of, as you know, plastic surgeons that are not getting into this field, and so this is just a letter of the editor that we wrote about cautioning them to make sure that they get a letter from their mental health provider for top surgery, and that can either be for trans men or trans women. Progesterone does not have much effect on breast growth, and it's usually estrogen that will have the effect. And we're really talking to our patients more and more about getting breast augmentations, because once they go off estrogen, if they go from oral estrogens to they switch over to iron injections, they will see a little bit of a decrease in their breast size. Normally the breast size they get is about half a cup to about a cup full in terms of breast growth. If you're a mental health provider and writing letters for patients, there's certain characteristics that need to be in that letter. That is the patient's associated diagnoses, in addition to the gender dysphoria need to be in there. Obviously a brief description of the clinical rationale, why this patient should undergo surgery, and also the length of the relationship that the mental health provider has with the patient. These are all critical factors that need to be in that letter that you're writing the letter. We have a large team. We have a urogynecologist, endocrinologist, urologist, colorectal surgeon, and then of course Lauren is our director of concierge. This is typically what an operating room looks like in the outfit when we're doing phalloplasty, for example. So we have multiple operative sites. We have at the university a lot of medical students, a lot of residents. And I think one nice part about this is that you're increasing the awareness of more and more people. And every time we have a case like this, everyone wants to be a part of it. And again, I think increasing the awareness and making this, normalizing the situation in these operations as much as possible, I think it's always in our best interest. As far as hormonal therapy, we recommend stopping hormonal therapy 4 weeks before the operation, particularly in trans women. That's again to avoid any clots in the legs. And in trans men, we also do it, but it's not as important. Anybody with HIV or hepatitis, we operate on everybody. Just have to make sure they're medically optimized for the operation. The last tip if you're a trans woman, for example, and so you're a male within your insurance, leave that gender marker with your insurance until you fully transition in terms of your operative, from an operative standpoint to whatever point you want to go to. As Dee mentioned earlier, everyone transitions when the time is right for them. And this is something I always constantly have to tell the nurses. They're like, oh, why does this person wait till so late? Everyone, you can do it either in 2 years or you can take 40 years for your transition. It's whatever's right for you. And obviously, you can just have your breast augmentation done if you're a trans woman and not get bottom surgery. And as long as you feel that you're no longer having dysphoria and you feel like you're transitioned, and then that's the point that you're transitioned, and that's it. You're complete in terms of your, in terms of the patient. So you don't necessarily, obviously, I'm speaking to a very knowledgeable group here, you don't have to undergo every single operation if you'll transition, whatever is right for you. We don't consider this elective surgery. It is medically indicated, and there's plenty of studies showing a quality of life in patients that are transgender that have undergone operations, that's basically it's an undeniable beneficial effect from undergoing the operation. So we don't consider this medically. We don't consider this elective surgery. It's certainly medically indicated. There's a study we did at the university, basically just showing what factors patients feel allow them to pass more. And this is both internally and externally. We had 84 patients fill out the survey, various income groups and education. And one thing that we found internally that our transgender women felt that was important for them to pass was their legal gender change, the hormonal therapy alone for 96% of patients, breast augmentation, and from a face standpoint, it was the frontal bone setback. So a decrease in the area, the prominence of the brow region. I'm going to show you a lot of pictures of that. For trans men, it was the mastectomy, speech therapy. Some of them really don't need it because of the testosterone does have a pretty good effect on them. The hormonal therapy, and then just changing the way they dress, simple things like that. As far as the more external manifestation of the patients, for trans women, again, the frontal bone setback, and then it was removing body hair. So electrolysis or laser hair removal. For the trans men, it was again the chest reconstruction, but they still found a good effect from breast binding if the breasts aren't too big. So these are some of the common procedures that we do, and I'm going to go through a lot of these, and a lot of this is going to be a little bit gory. This is a trans woman who did before estrogen therapy, and just to show you the effect from estrogen itself, really significant softening of the skin that causes that the estrogen can cause. So this is again without any surgery, and just use the effects of hormones themselves. The mandibular angle is an area of the face that we commonly use to remove to feminize the face. We do this all from an intraoral approach. Before doing that, we get x-rays, and the area that we commonly will reduce is these angles here. And it's very important to get x-rays before this to make sure you're not going to disturb any of the tooth roots or any of the nerve anatomy. This is the Adam's apple, which we commonly reduce here, and that's an intraoral approach for the mandibular bone reduction. Before, that's shaving down the bone. This is the amount of cartilage we remove. Again, this doesn't disturb your voice, it's just external, and we don't get close to the voice box itself. That's the amount of cartilage removed for the Adam's apple, or thyroid cartilage reduction. There's a patient at 3 months. Obviously, a lot of our patients don't live in Florida, so we end up getting a lot of pictures from that just sort of mail in. So this is her at 8 months post-operatively. Again, just mandible angle reduction. 32-year-old, again with the thyroid cartilage reduction. The nose is also an area that we do reduction rhinoplasties on to help feminize the face. Everybody's nose is a little bit different, but again, this is an area that can commonly be reduced. And this is the thyroid cartilage reduction shown here. And this is, again, just showing a decrease in the Adam's apple prominence, and then it's just slightly smaller nose. And she's still undergoing other procedures, but this is one of the steps towards feminization of the face in her. The upper lip, lip is longer in natal men than in natal women. And so this is another area that we can use to feminize the face. If you create a shorter lip length, then that's a way of feminizing the face. One way to get this approved by insurance, a long lip can cause lip biting. So if you have a doctor who's willing to kind of put things through insurance, then this is a good diagnosis to use. And we commonly will anybody work for insurance companies? We commonly come up with crafty ways of getting things approved by insurances, because there's many ways you can. And so an example, this trans woman, she was an Army vet. This is a long lip length, as you see here. This distance from here to here is obviously longer in natal men, and that's the area that you can shorten. And a common procedure we use is a bullhorn lip lift, as you see here. Looks like a bullhorn, and then that area can be lifted. And you see here early post-op, and and then here she is again, just again with a decrease in the lip length from the filtral columns to the upper portion of the mammalian border. We always look at the hairline. This is a very feminine hairline in this trans woman. So in a patient like this, and with a very, not that long of a forehead, but very bothered by her prominent brow region and her nose. We can do the procedure endoscopically to decrease the brow region. We do, however, have to have a lateral cephalogram, which shows here that this anterior table is quite thick. So that can be reduced in size. If this was too thin, then you need to do a frontal bone setback, which I'm going to show you. And this is just endoscopically us burring it. So that area is already blurred, and this area is yet to be blurred. And then, of course, with the reduction rhinoplasty, significantly feminizes the face of her, and again, decreasing the prominence of the brow, you see here. And there's another post-op shot, about 8 months. There's a girl that's in the video. She's been a big resource for us, that's for sure. She's always on the camera. So this area is a little bit prominent in her, and as well as her nose. She wanted that reduced, and again, that can be done endoscopically. We always measure the thickness of this, and if this is greater than 3 millimeters, that's a frontal sinus anterior table. If that's greater than 3, then we find that we're able to reduce the size of that and actually make an impact on that area. Here she is, endoscopic reduction and rhinoplasty, a little bit dark image. Here's a 46-year-old, looks a little bit aged, large nose, kind of long forehead, and she was a candidate for reducing that area and bringing down the hairline, which is another way, obviously, to feminize the face. The video still works, so I guess that's just shaving down the anterior table of frontal sinus. And there she is on the table. You can see before shaving this down, and then after, you have a lot smoother contour. And again, this is one of the areas that's most impactful in terms of feminizing the face, is decreasing that brow region. Here she is early, a 3-month post-op after reduction of that area here. In this particular patient, very prominent area here, she also wanted a lower hairline. So in this particular patient, you can get another lateral cephalogram, and then it's hard to tell here, but this is a very thin bone. So this particular patient needs an actual opening up of the forehead region and formal setback. So this was certainly gory, but we take out the anterior table, as you see here, and then we put that on the back table, as you see here, and then continue to burr down the areas laterally. And with the basic burr that we use in that area. We wire these segments together. Now we're using plates and a mesh plate. And there's that patient on the table. And then at 6 weeks, again, a significant feminizing of the forehead, and certainly a lot flatter. We have to use this incision here right anterior to the hairline, because if you want to lower the hairline, you have to remove scalp that doesn't have any hair to actually lower it down. But that actually ends up fading out quite well. The patient just lateral through. And there's her at 5 months post-op, and then 3 years post-op with a sustainable result. And not all patients need surgery, so we always are cautioned with this body dysmorphic disorder. It's sort of like the Michael Jackson type of syndrome, maybe rest in peace. But this patient had already had 16 operations on her face, and so we're certainly not in the business of kind of reoperating on our patients. This is a patient we just turned away for surgeries. I just thought that she was already beautiful, and so this is a patient that you have to be careful with. They may have body dysmorphic disorder, and so I think these patients just need more encouragement rather than reoperations, because then obviously reoperation can lead to more scar tissue, and it can lead to a disastrous result. And she's actually doing quite well. I got a follow-up on her. She never got another operation on her. She's quite happy. Precaution, silicone. Silicone can be dangerous. Not all patients have a problem. Of course, I get a skewed view because I see the patients that end up having problems with silicone. And now I'm getting a lot of patients that have had silicone and have not had any problem, but their friend did. They got injected and they want the material out. And then this is an old paper from the Netherlands just showing how, unfortunately, if you have a thin trans woman and she's got no fat to give, then what are you going to do to augment her butt? Silicone implants don't do that great. There's a lot of malrotation. So there aren't that many options, so I can see how patients end up succumbing to the injections, but it can lead to problems. In this particular paper, these are areas that were injected, and then these are the problems that the patient's got, infections and then, swelling of the legs, inflammation, scarring. And then this is how it was managed, sort of local incision, observation. We've come up with procedures where we can do liposuction of these regions. And here's the patient, an example of a patient that had that problem with the silicone injections because darkening the skin. Here's another patient done by another plastic surgeon that actually excised it. Please don't succumb to this. There's usually not that bad that you even have an excision like this in skin graft. So we've actually published 2 papers on this topic. We started doing these cases about 6 years ago where we use ultrasonic and suction liposuction. So what we first do is take fat, if the patient has any fat to give from the hips, the abdomen, we prepare the fat, and then while that fat's being prepared, we then go in and suction these areas. This girl's butt doesn't look that bad, but she couldn't even sit down because of pain. So we remove ultrasonic liposuction. These are the stuff that we normally obtain. They look like little silicone balls with gel on the inside. And then there's some material again that we remove. And there's a patient right at the time of removal. And here she is now at 6 months. So we actually did liposculpture on her because we take fat from the good areas, we remove the bad stuff, as you saw those beads, and now inject it into the muscle and inject her own fat into the muscle, into the subcutaneous tissue. And now she has no pain. She could sit down. So it actually was she's one of our first patients, and this is one of the patients that really led me to keep doing these procedures. And there she is post-op. Different patients that have had silicone, so they come in a wide variety of shapes and sizes. But we published this, and now there's a lot of other institutions that are doing these procedures, thankfully, so they're not leading to that wide excision with skin grafting that you saw in other patients. So again, it's liposuction and lipofilling to treat this problem. And again, we published that about 5-6 years ago. As far as the chest goes and augmenting the chest in a trans woman, typically the nipple areola complex lies lower in a cisgendered male, and so this is an area that we kind of need to get up. So a lot of the implants that are put in, you hope that this rises up, but if it sits that low, sometimes patients will need a mastopexy at the time. The implants we use are the same that we use in cisgender women. We've been putting it under the muscle, but in some cases now over the muscle, and there's really no ideal plane yet, something that we're sort of evaluating, and not just us, that's everybody. So here's a patient prior to surgery and had a pectoral implant. At times you have to go inframammary because the nipple areola complex in a natal male is a lot smaller, so you can't get a large implant in that incision. So we opt for an inframammary approach below the breast. That's her early post-op after her operation. Another patient shown here at about 7 months post-op, again, with an inframammary approach to her augment. And again, the breast augmentation procedure does significantly help patients in passing, and this has been well documented in studies. Another patient with a 600cc implant, no longer having to use these sort of gels to sort of stuff the breast. Here's a 48-year-old. She's a flight attendant, and most airlines cover gender surgery. I haven't seen any that doesn't, so which is great. Nipple areola complex is in this area. You're gonna have to, if you put an implant in there, you're gonna have to do a mastopexy on her, which is a breast lift, and that's what we did for her, and that's her early on, 2 months after the operation. As far as bottom surgery goes, not all patients need to have everything removed down there. Some patients will just opt for orchiectomy. The benefits of the orchiectomy is no longer need spironolactone, which is a testosterone blocker. The adrenal gland, still, which is right above the kidney, still produces some testosterone, but not much. So benefits again of the orchiectomy, it's not that expensive. You can do it as another patient, again, using penile skin conduit for the canal. Just since we're talking about art here, I think it's very important, this looks dark, but to deliver the urethral meatus within the vaginal introitus. So it's really dark here, unfortunately, but the vaginal canal is here, the urethra is here, and the clitoris is here. You don't want the clitoris like way up here. I mean, it needs to be sort of within the actual introitus. And again, this is, I think, when we give these lectures, we always talk about the clitoris having some sort of a hood. And it doesn't have to be very large, as you see here. It's one thing we sort of learned as we've done more of these. It doesn't have to be very large. It's not large in a cisgender female, so it certainly doesn't have to be large in a transgender woman. And with a little hood, and again, the urethra rip just below that. And unfortunately, we've seen some, and I'm going to show you some cases of what we've seen with that not even in the correct order. I would love this picture. This was one of my first cases. It was a 62 and 65-year-old lesbian transgender female couple. They came in for surgery, got surgeries done back to back. Just a good example of the fact that, you know, it's completely different from one sexual preference. It's not uncommon to have a little revision done. This person had one revision. She does some nude photos and then some porno as well. So before this revision, she just showed me, you know, she got spread legs. She's like, "Do you want your workout here?" And I'm like, "No, let's do so, but anyway, and she's doing quite well now. She's a revision done in 3 months. There's another patient married to a guy for 5 years, and it really just showed me the, you know, love, because the guy did not care at all whether or not she had the operation or not. She was just doing it for her. So it's you know, and this is obviously she was packing. You can see a little imprint here. So this is the right after surgery, and then we've gone on to reduce the size of that clitoris. I thought it was a little bit prominent, and that's just showing the dilation, which is important after this operation. There are some surgeons out there, if you get this operation done, that will tell you, you gotta dilate, and if you don't dilate, it's gonna contract down. But I've heard many surgeons sort of blame the patient, but inherently these penile skin conduits can contract. And even if you're not having vaginal penetrative intercourse and not dilating, it still can contract down. So don't let your surgeon tell you it's your fault. This still can contract down, and you may need a revision operation if that happens. As far as the dilators you use, this was one of my patients early on in our practice that found this online. Actually, she bought it in Germany, and she's like, you know, can I dilate with this? And I didn't have as much experience at the time, and I said, it looks pretty cool, go ahead and use it, but it is too abrasive and ended up causing a fistula. So I strongly recommend smooth silicone dilators for dilation. Don't use any of these funky dilators because it can cause problems in the canal. And it's just an example of some of our cases here after dilation. Some patients will put a condom on it, some won't, but that's just a typical dilation procedure in the patient. Obviously, the prostate gland doesn't get removed with these operations, and extremely important for that to be surveilled. You have your gynecologist, if you're a trans woman, do a rectal exam, your primary care provider, or whoever doctor you're seeing needs to evaluate the prostate. The prostate-specific antigen is a laboratory study that doesn't always detect prostate cancer. And just know that typically in medicine, if you live long enough and you have a prostate gland, it's going to get cancer at some point in your life. It's very common. It doesn't always mean it's a bad thing, that it's a bad thing, you're going to get a stage 4 and die from it, but it's a gland that has a high malignant potential, transformation potential, so don't forget about that prostate gland. And this trans woman at 41 years after surgery, she ended up getting prostate cancer. So don't ignore that gland. If you're a trans man and you still have your uterus intact, and we'll talk about trans men in a minute, and cervix, so you need to have that surveilled as well. These are our statistics in our institution. Now, this is an intestinal vaginoplasty. We're doing a lot more of these. In the U.S., most people that get the intestinal vaginoplasty, they get it done because the vaginal canals decrease in size. They can no longer accommodate a large strap-on or phallus, and so they want a little bit more capacity, and so we usually go for the colon and intestinal operation. We use a sigmoid colon for that. And it's really a great operation, and we're doing more and more of these even in a primary setting. And that's just from the perineal space, so that clamp is in between the legs, and then we work with a laparoscopic surgeon, Dr. Heidi Bana, will then take a piece of the sigmoid colon, and that sigmoid colon then gets delivered, as you see here, and so the canal is made up of intestine. You will have some drainage, mucus drainage for about 8 months. I haven't seen it last much longer than that. I know Lauren Foster saw some blogs of guys that want to go down on girls that had intestinal vaginoplasty, but I mean, I think that's just dealer's choice. If you're someone that, you know, that eats ass, I don't think you're going to mind it that much. So it all depends on what your situation is. It's a really good operation, and we've done quite a bit of these intestinal operations. A lot of the older school surgeons don't do this operation because they don't really know it. So, but we do offer this operation and have had very good success with it. Some unfavorable outcomes. Patient done in Thailand, pretty decent aesthetic result, but the canal stenos down. There are, this is from a paper from Aventura Herald Reed, non-grafted vaginal depth augmentation. What they did there was sort of reopen the canal and then didn't use skin grafts and got about another inch of the canal. The more common procedure to open up the canal is to put skin graft around a conformer and then place that inside the vaginal canal. However, in this particular patient, it didn't work that well, so we went on to do an intestinal operation, as you see here. And this intestinal operation can accommodate a pretty lot of basically, that whole thing was able to be accommodated, so we had to bring in her favorite toy and to make sure that she was going to accommodate that. And it did. That's a picture of the scrotal graft. So when that penile skin's inverted, that's the scrotal graft that's augmented at the end. So if the phallus is like 4 inches or less, you usually augment with a scrotal graft like that. Sometimes these scrotal grafts don't work out. This patient's insulin-dependent diabetic and was a smoker, so she lost the scrotal graft. But she ended up doing okay in the long run. Just removed that scrotal graft. Another patient that we had a problem in, a little bit of wound dehiscence seen here that we're planning on revising. Here's another patient that had a cellulitis, a little bit of infection of the skin that resolved with just antibiotics. So these are some problems that can happen after surgery, but kind of minor compared to some of the other results, some of the problems that can happen, as I'm going to show you. Some adjunctive procedures we do to augment the labia. After this operation, the labia can lose a lot of volume, and so we commonly use dermal fat grafts, and that can come from a small incision in the belly or the upper thigh region to sort of augment the labia. This is a cisgendered female that we use dermal fat grafts to augment the labia majora, and we're also using that in our trans woman population. That's in the result of a year and a half. Here's some fat grafting in one of our patients that lost a lot of volume in the labia, and that's after fat grafting there. Another patient that had just kind of excessive show of the vaginal canal, and again, a dermal fat graft in that area can accommodate just a better aesthetic result. These are some of the complications that we're seeing. This is a penile reconstruction, and again, we just have to be careful. You know, when you're choosing your surgeon, do the research on the surgeon. Unfortunately, there's some surgeons out there, and this applies anywhere, and they'll tell you that they did 200, 300, 400 operations, and you just have to be careful. You know, just make sure you're going to a center that's got a decent reputation, good reputation, and is sort of the lone healthcare provider that you've never heard of, and I know you blog a lot, and you're on social media a lot. You have a great network, and that's one thing. And usually most patients are smart, but some of the patients end up succumbing to these kind of results. Another patient that didn't have that division, the resection of the corporal body, so whenever she got excited, this would stick out. There's another patient that got done with an untoward result. Another patient with prolapse. It's hard to tell here, but this is just the penile skin collar just completely prolapsed out. Another patient with anorgasmia had an amputated clitoris. And this is one of the craziest results I've seen so far, where the anus is here, the urethra is here, the vaginal canal is here, and the clitoris is like not really to be seen. So, you know, this is really, again, what you have to caution for. This patient that we're still planning on doing, and unfortunately, just be careful where you're choosing as your surgeon. That's all. As far as female and male operations, so moving on to trans men operations. The male chest, as you see, it's a smaller nipple-areolar complex. The majority of patients are getting a double incision mastectomy approach. And commonly what we use is this schematic by Stan Monstring on whether if they get a double incision mastectomy, we're going to use the areolar approach to resect that breast tissue. In this patient, 16 years old, with really no ptosis. Ptosis means that nipple-areolar complex lies below this fold. So this patient has no ptosis. We're able to really resect all the breast tissue through a cut in the areola. That's from the left and right chest. And there's that patient at 3 months. A little bit of scar retraction, but with some scar massage, this ends up doing quite well. Another patient after circumareolar approach for resection. I'm doing less and less of this approach because you end up needing revisions. So this is a patient now I can do a double incision mastectomy on. And here's another one at 3 months. Again, the double incision mastectomy, you can't see the scar that well here. It really just lies along the lateral border, the medial lateral border of the pec. These nipples get taken off. We decrease the nipple size and then sort of put it back on as a free graft. In darker skinned individuals, this takes about 9 months to a year to regain that melanin, the pigmentation, but it actually usually does quite well, and if not, you can always tattoo it. Now here's an example of a patient where we're not following the guidelines of WPATH strictly. This is a 14-year-old, lives in Miami, who obviously you see breast binding, and in a patient like this, we usually will have them present with 2 letters of recommendation from their mental health therapist for surgery. The patient came in with both their parents, and so even though top surgery is normally done at 16, these are exceptions that we make, because this is kind of a miserable way to live, especially in a hot area. They're wearing heavy shirts in the summertime in Miami. It's not a good way to live. So this is at 5 weeks we did a mastectomy on this patient. We commonly combine hysterectomy and oophorectomy with the patient if they're ready for bottom surgery. So here's a 16-year-old that had that, and that can be done very safely, combining the top surgery with bottom surgery, at least at this point. Kind of flow through this. As far as penile construction, we primarily do this to treat the gender dysphoria, and that's why we do all of these operations, and that's really our main goal, is to treat the gender dysphoria. So secondarily, to have the patient allowed to have intercourse with their new penis, allow the patient to have orgasm if possible, and usually they do. The clitoris, as you'll see, is based at the base of the phallus, so they will be orgasmic. And then to be able to void through the construct of the phallus. Non-surgical options until they get the phalloplasty is this, and I have many patients that will have intercourse in this fashion, but it can be cumbersome. They have to run to the closet or run to the bathroom to put this on. I've had patients, the wife tells me that they have to turn off the lights every time before they have intercourse because they don't want to see the strap-on going on. So it can be a problem for one's relationship. So more and more patients are getting phalloplasty now, and it's because insurance is covering it. There's packers that patients use until they get the phalloplasty. Again, not everyone needs it. If they feel like they don't have any gender dysphoria at all, and they're using packers, and they're quite happy, and are in a happy relationship, if they want a relationship, they can just stop there and use a packer for the rest of their life. There's obviously no problem with that. But I do have some that their relationships influenced by this and compromised by these packers. So these are patients I think are good candidates for phalloplasty. Patients can actually urinate through these packers. I've seen patients urinate through it. You can shoot the urine through here and it comes out the tip. So you can't really tell if you're at a ball game and you're right next to someone with a packer. But packers can cause some problems. Here's a patient that went in with right hip pain to the ER that forgot to take their packer out. So obviously when the radiologist is looking at this, they're wondering what the hell's going on. It can get a little bit embarrassing for the trans man that has a packer in place. Here's a patient that came in because their partner had a packer, and the packer went all the way into their anus. And so they had to have it surgically removed. So this is a CAT scan, that's a packer. So this patient had to go to the OR to get that removed through the anus. So it can cause problems. So again, something to be aware of. Typically when we do the phalloplasty, the patient needs to be living in that gender role for at least 6 months to a year, 2 years. I can tell you we're doing these cases a little bit earlier and earlier every day. Patients feel they're wrongly gendered from age 2 or 3 years old, 5 years old. So, and as soon as they say that, then, I don't go into too much how long are you, identifying as such and living, dressing like a male or whatever, because they might not be able to dress as a male at the current time in their life, but they know they're male inside. So I think once they get this operation, then they can really work, come out. 2 letters are required for bottom surgery. I think it is important to get a hysterectomy and oophorectomy. Again, more for cancer reasons, because these trans men don't want to go to OBGYN. They don't want to get a pap smear, and if the cervix is there, you can get cervical cancer. We do have a program now at the University of Miami where we're doing, encouraging patients to do self-paps and bringing in their results to us, or bringing in the pap smear swab to us to detect for cervical cancer, because again, they don't want to go to the OBGYN, and we provide that service obviously as well in our clinic. Before insurance started covering this procedure, the metoidoplasty was extremely commonly done. There's Marcy Bowers, huge in the trans community and in surgery. She does a lot of metoidoplasties and does them well. Patients are urinating in standing position. Some patients state that they can have intercourse with this. I think it just seems like it'd be a little bit difficult, because I feel like you're creating a micro penis situation, but if the patient feels like they are less dysphoric with a meta, that's it, they're good. But some of them, we're not writing a paper on the meta, metoidoplasty, or phalloplasty, because it's still, a lot of the patients still aren't happy with the length of they're getting from metoidoplasty. The procedure, the flaps that we use commonly are the radioform flaps for this, and I'm going to show you some examples. There's no study showing that the back flap is better than the thigh flap for a phalloplasty. Tristan Cotton is a trans man, very vocal in the trans community. He's got a book called Hung Jury, and so he did a survey on trans men, 150 of them, and reported, and this is the best data that we have to go to is his surveys, that as far as the phalloplasty, the forearm has 84% tactile sensation, which is better than the back flap, which is the musculocutaneous and cincipes dorsi flap, which is better than an anterolateral thigh flap, and definitely better than the abdominal flaps that are done. As far as orgasm goes, also the radioform flap, again, much better than the back flap and the lateral thigh flap and the abdominal flap. And this is the radioform flap of ours. So the options we give our patients are whether or not they want bone in their flap or not have bone, but we do recommend a hysterectomy and oophorectomy in these patients. We pre-laminate our urethras, and I'm going to show you what that looks like. We do use vaginal mucosa, so we do this at the time of vaginectomy. So the vagina is removed in our trans men. Commonly in a tube within a tube flap. However, we do use, again, vaginal mucosa and buccal mucosa. So in our first stage of the operation, we use this mucosa from the vagina when it's removed, and then tissue from the mouth, the buccal mucosa. We wrap that around a Foley catheter, and then put that around the Foley catheter, and it's just sewing the mucosa together, and then we lay that in the form for the first stage, and that's just using buccal mucosa. We've also used uterine mucosa in the patients that hadn't had the hysterectomy or oophorectomy yet, and published that as well. So that goes then under the forearm, and then that's there's placement under the forearm, and then we sew that up, and the patient then undergoes urethral lengthening. As you know, the urethral meatus is inside the vaginal canal, so that needs to be brought out. And then the vaginal canal is removed by our urogynecologist, Dr. Medina. So at the end of the operation, the patient now essentially has a metoidoplasty appearance without scrotoplasty. So they're urinating from here, and as far as the forearm goes, this is another example. The forearm goes, they go home like this for about 3 months. So this becomes the urethra. So this is going to be the flap that's transferred for phallus. So they irrigate this catheter out for about 3 months, once or twice a day. They're able to go back to work. They just put some gauze distally and proximally. And then we come back to the second stage. And this is a little bit gory. The clitoris has all the tissue removed off of it. It's probably good if the lights are a little bit bright here. This is blood vessels from the abdomen, and these are the veins that we plug into and the nerves. This operation takes about 12 hours, maybe 10 to 12 hours. And then we sew up all the nerves, and then again, showing up the reconstruction of the nerve there. The Foley catheter gets removed. That's the clitoris. The clitoris gets placed at the base of the phallus. So patients have orgasm when they have full penetration of their phallus. You can't just use the tip and have an orgasm. Usually you have to have stimulation of the clitoris at the base. So again, you have to have deep, full penetration for orgasm. As far as the constructive length, patients will always want they've always requested longer than biological length. The average length about 5.5 to 6 inches in natal males. So we have to set realistic expectations. Sometimes I have a trans man that's like 4'8" and wants a 7-inch phallus, and their forearm's only. So we have to tell them, just be a little more realistic. And I've had patients that come in with like photos of, porno shots from Blacked and say, hey, this is what I want. And so again, you have to have realistic expectations in this. Again, that's a normal phallus length, about 4.5 to 6 inches. We also stress to our patients that girth is more important than length. And this is a study showing that girth was more important than length in these cisgender women that were heterosexual. So walking you through a case, here's a skin graft used for the pre-lamination. The patient had a tortoplasty by Marcy Bowers, but it was long enough for intercourse. So here we did a pre-lamination of the form. Here's now when we're raising the flap to transfer it down to the phallus. This is how the scrotoplasty is done. And then we bring down that labial tissue to create the scrotum. And that's the tissue at the forearm. And then we bring that tissue down to the groin level. We take the Foley catheter out of the bladder, and then bring the phallus to the groin level. We sew up the urethra first, and then sew up the arteries and veins. And then here's that patient. Immediately after surgery, we use a suprapubic tube placed here to drain the bladder as well. And here's what the forearm looks like in this patient. Not a bad donor site, and that's why I really refer the forearm. And there's that patient right before getting their implant. This patient, just talking about art, and it's a lot of the, when you're selling your art, it's who you end up meeting as well. Because if you get in front of the right audience, getting in front of the right audience can help promote your art even more. And sometimes it's luck, and sometimes it's sort of being strategic about who you end up getting in front of. And this particular patient, he's from New York. He's very prominent in the trans male community. So this guy goes to Black Trans Man Conference in Dallas, and they have show and tells there. And he did a show and tell, and everyone was like, I want what he has. And so we ended up getting a ton of patients because of this guy, and he's really just a great guy. Thankfully, he had a great result as well. Another example is a 27-year-old with regular, long hypertrophic clitoris, and then that's a radial forearm flap in him. And here's another guy, 26 years old. Any forearm tattoo is going to be transferred down to the groin level. And so sometimes patients will have tattoos of their kids' names and stuff like that, so you got to use the other side, because obviously that's not something they're going to want on their phallus. And here's a patient this is a little bit artistic, right? But I didn't do the tattoo. And here's this guy, he's really proud, and he's a great guy as well. As far as the donor site, this is what the forearm would look like. Some patients don't want the radial forearms. They're concerned about this tattoo, concerned about the skin graft on their forearm. But I do think it's certainly better in terms of sensation, and so that's why we always opt for the forearm. And again, that's it's not that noticeable. Here's an anterior lateral thigh flap, and even though this is concealed in shorts or in jeans, and so you can be sitting at with a short sleeve shirt off, a short sleeve shirt on, and not have a forearm skin graft. I think if you're going down on this guy and you've got this huge skin graft on the thigh, I don't think that's going to look too hot. So Priscilla's flaps, and we publish this as well. The coronoplasty we do at the time of the operation, and we use labia minora tissue. So the coronoplasty is making the glans penis portion of the phallus, as you see here. Another way to make the coronoplasty is use palmaris longus graft, and so as an example, again, another phallus that we reconstructed with the palmaris longus graft. As far as the testicle goes, we commonly use fat injections or muscle to put in there. And I always tell patients, don't worry so much about the testicles, it's more about the penis length. And we actually did this in a survey. We had 80 respondents to see what they thought was more attractive. And always the tip of the phallus lying lower than the bottom of the scrotum was considered the most attractive in 67% of our respondents. And certainly they can cause a lot of problems, certainly good for these men, these large scrotums and these implants. So I don't put in scrotal implants in these patients. I either use fat or I use muscle. As far as erectile function goes, we use traditional implants that are used in cisgender males. This is a patient that didn't want an implant at first and then sent me this photo saying, can I please have an implant? So it is important to complete the reconstruction in them. And here's the patient, again, at the time of implant placement, and here he is post-op with a dual malleable prosthesis. I've done 99 of these cases so far, so basically we're getting to the point where we can go from here to here, and then a donor site tattoo. And that's basically our goal. And of course, to be able to give the sound of it as well. And to be able to urinate through the tip. These are some of the complications that can arise. This is called a supersonic transporter deformity, and we're coming up with ways to sort of fix that. And this is kind of well-documented problems that can happen in any trans man and even cisgender men as well. There's a meatal dilation that we do to try to prevent stenoses on the tip. Not all patients need to urinate from the tip. There's a phalloplasty that we did, just showing by another surgeon, showing that who still had his vaginal canal, just showing that you can do a procedure so that they can then urinate at least from halfway down the shaft, and that was an example of one there. So fistulas can happen, and I'm going to end with this slide. Fistulas can happen. However, again, with using different techniques that we've been able to find here in the gracilis flap, we've been able to do a wraparound around the gracilis flap to then minimize the fistulas that our patients are getting. This is one of the main things that surgeons are struggling with. And thankfully, when we started using these gracilis flaps, we now have no fistulas, but we still have other urinary complications that you can get. And a lot of our patients end up living in different areas, so always find a good reconstructive urologist for them in different areas. And in New York, we have a good one. Lee Zhao is a great reconstructive urologist. And this guy Doogie in Oregon, so I always get my patients to these areas in case they have issues, especially if they're liver fried. And this is our pedicle gracilis flap paper that we did on our patients to try to avoid fistulas. So far, no fistulas with this technique. We presented this in Serbia and Amsterdam, and I know a lot of surgeons in Europe are not using this technique. So we're trying to evaluate our patients every time we do an operation to try to minimize the complications you can get. And the phalloplasty is a little bit harder. There's microsurgery involved. They're in the hospital about 3 weeks. But it's certainly worth it for a lot of our trans men, so really they do this for it. I'm just going to end with there. If there are any questions, feel free to ask.